So the first new drug I wanted to talk about is a drug called bictegravir. Now, bictegravir is an integrase inhibitor. This is being produced by Gilead. So it's an integrase inhibitor that's very, very similar to dolutegravir, which is the integrase inhibitor contained within Triumeq that some of you may be familiar with. The reason I wanted to present this data in particular is just to introduce the concept that I think Gilead and ViiV are taking very different approaches to how they're developing drugs and treatment strategies in the HIV market. So bictegravir will only be co-formulated in a single tablet regimen combined with TAF, the newer version of tenofovir, and FTC, which is a drug many of us will be familiar with that is contained currently within Truvada and within other single tablet regimens. But this study was a big phase 3 study, and it compared this bictegravir single tablet to Triumeq. So they really did go for the big guns. They went for the big competition, Triumeq being really a gold standard of first-line therapy with very good viral suppression rates and in general very well tolerated. Now they did show that these two pills worked equivalently essentially against the virus with very good viral suppression rates of 92 versus 93% at 48 weeks. And failing either treatment was very rare with both regimens. One of the questions that was also raised about this drug by Laura Waters from Mortimer Market was a question about whether or not Gilead will be making this agent as a single tablet. And I think particularly talking to a UK audience, this is very important because we know that TAF is fairly limited access, fairly restricted, and if bictegravir comes in a single tablet with TAF, it feels like it'll be quite a long time before we get access to this drug in the UK. And Gilead were quite clear that they're not going to produce this agent as a single agent. So bictegravir will not be made on its own. This means we can't combine it with other generic backbones that might make it cheaper, and also they won't be looking at any innovative strategies, so they won't be looking at what we mentioned before, which is maybe using the drug with one other drug instead of two other drugs. I wanted to talk about injectable agents. So I mentioned these at the beginning. The big study, as I've said already, was a study called SWORD that looked at people who were already undetectable and gave them injections of an integrase inhibitor called cabotegravir and a non-nucleoside called rilpivirine. So cabotegravir being very similar to dolutegravir, but injectable. So the SWORD study has already shown that injectable therapy is as good at keeping you undetectable if you're already undetectable. What was presented in Paris was some further safety data around injectable therapy, and this really related to bone health. So it was really about osteoporosis. Now, they only looked at patients at 48 weeks after they'd switched to the injectable treatment, and what they showed was that your bone density at the hip on bone density scanning improved significantly if you were switched to the dual therapy injectable regimen. Now, that again sounds really promising until you remember that actually a lot of the people who switched onto the injectable treatment were already on tenofovir. And tenofovir, we know, can reduce your bone density a little bit. Doesn't necessarily make you more at risk of fractures, but we do know it can reduce your bone density according to scanning. So we don't really know if this switch was safe because the new drugs are particularly safe, or whether it's just because you stopped being on tenofovir. So again, we have to interpret this data with some caution.
One of the other interesting stuff was on HIV self-testing. I was involved in a study here where we're trying to get the African community to sort of do your self-test at home and post it back. So it was interesting to hear other countries who were also trying to get people to self-test. In the UK, there was the THT trial in Lewisham. In the United States, it was a program called eStamp, where they recruited gay men online to test. And it sort of got people interested in testing, especially those who had never been to a GAM clinic or sexual health center to test. And in South Africa, it was also trying to test it on young girls and women who sort of see how much interest there is, in self-testing, and it was quite. People were up for it. In Zimbabwe, they tested it on the female sex workers, and they all said, I would recommend it for my own family or for my clients so that we know where we are. And in Kenya as well, it's sort of the whole thing is people like it. People who don't normally go out there to test would rather have it. And it's good for people who are at risk of infection who prefer that confidentiality. So it could also increase the frequency and timeliness of HIV testing, which is one of the biggest goals on the UNAIDS 1990 targets. The presentation on menopause was very also interesting because we know that there's over 2.5 million women who are over 50 who are living with HIV, and the highest are in sub-Saharan Africa. And there's a risk that the women living with HIV will develop menopause early. I'm sure Shima will have something to say about that, so it's still being studied, so we don't have actual information whether that's true or not. But there's also this general awareness of raising menopause with the healthcare professionals. Most women probably see male professionals who might not recognize these signs, so it's sort of making women aware that if you start feeling anything different, you need to let your doctor or whoever you see know. So the take-home messages from that session was, we should ensure that all young women have access to PrEP, which I think was a big topic at the conference, and any other ways of protecting themselves. I think you have all heard from the Durban conference about these young women who sleep with older men for money. So we need to empower those women so that they have access to protect themselves in other ways of taking care of their bodies. So option B has been held as one of the great public health achievements of recent times, especially in countries where they roll it out. But besides protecting mother-to-child transmission, we need to focus on maternal health. It's still a big concern in countries, in some countries in resource-limited settings.
So the biggest, the most widely read news story of the whole conference was, I think I'm right in saying, was this study. Very simple study, very simple design, opposites attract, 343 positive/negative gay male couples. Long-term relationships, committed relationships, one positive, one negative, what I've heard called magnetic couples in Australia, Thailand and Brazil. And this looks like an awful lot of sex, but if you multiply 343 people over about 2 years, it's really not that much. No HIV transmission in 16,889 occasions of condomless anal sex. And the third with the HIV positive partner is top. That matters because you're 10 times at least more likely to transmit HIV if you're the insertive partner than if you're the receptive partner. Now, we can add to this the partner study, which reported its most recent findings last year and found no transmissions in about 20,000 condomless anal sex acts between gay men. So between the two of them, we have getting on to 40,000 acts of condomless anal sex in which there has not been a single transmission. There were infections in this study. There were in partner 2, 3. All of them came from people outside the main relationship. All of them came from playing outside. Interestingly, in this study, this was one difference with partner. With partner, you had to enter the study undetectable viral load. With opposites attract, you could join the study as soon as you were diagnosed. And in fact, 40% of the guys in the Thai site were not on treatment when they joined the study. But what happened was that they were actually very good at using condoms while they were still detectable. The positive guys used condoms while they were still detectable. And it's only, I think, less than 1% of all condomless anal sex acts were with a positive partner who had a viral load that was over, I think it was 200 was the limit. So, in other words, these guys were very good at using condoms when they needed to, but when they stopped using condoms, there were no transmissions. PrEP works if it's only used occasionally. This is from the French study, IPAGAY, very important study, because it's still the only randomized study we've got where they told people to take PrEP intermittently, as needed, on demand, as they put it. Take a double dose before you think you're going to have sex, and if you do strike lucky, then take one each in the next 2 days. That's what they did. But there was also a question. A lot of people couldn't believe how effective IPAGAY was. Remember, it was 86% effective, just as effective as PROUD, where people were taking PrEP daily. And they thought that might be because a lot of the guys in IPK were pretty active and were essentially taking PrEP daily anyway. So they did a sub-study where they only looked at the people who were on record as saying they had less than the average number of sex partners. It did work, even with them. So it looked at the people who had less than average amounts of sex, but said they used PrEP consistently when they did. The pretty green thing is the illustration of the adherence careers of people in IPK, showing that people were on and off PrEP all the time. If you're on PrEP, you're in green. If you're not, you're white. If you're a horizontal stripe, you're one of the trial participants. So it shows how tremendously variable people's PrEP careers were. So there were 6 infections on placebo, because it was a placebo-controlled trial, but none on Truvada. So it did work even for the people who had less sex and might only be taking PrEP once or twice a month. And that's because it reaches maximum level within the rectal tissues after 2 doses. This is a slide from Sheena McCormack. But, and this is a big but, IPK was in men who have sex with men. It wasn't in women. And in vaginal tissue, it seems to take at least 5 doses before it reaches maximum level. So intermittent PrEP might not work in women. We don't know yet. Nobody's done a trial.
So just because it was such an important thing in the conference, there was a lot of talk about this thing 90-90-90. So for anyone who's not familiar with what that means, these are the targets that the United Nations are setting for every country. It's about, in each country, 90% of people who have HIV knowing their status, 90% of people who know their status being on treatment, and 90% of people on treatment being virally suppressed, having an undetectable viral load. So there is a lot of progress around the world. At the top line there, you can see that across the world, it's 70, 77, 82. And that's even in some of the hardest hit part of the world, Eastern and Southern Africa. You can see really impressive figures. And UNAIDS, the United Nations Agency's analysis of this is basically because there's political commitment in these countries. And if you look at Western and Central Africa, where frankly there's much less political commitment, the results are really poor. I mean, they're saying that money is important, but having political leadership in each country is as important as well. And you can also see that, I've put the line on there for Western Europe, so you can see where we are. And obviously, there are less resources in Eastern Europe and Central Asia, but there's also a lot less political leadership there as well. And perhaps the biggest research about 90-90-90 at the study comes from Swaziland. So Swaziland is one of the worst hit countries in terms of HIV. It's a country in Southern Africa, quite a small population, very rural, but 1/3 of people living with HIV. And this is really probably the first time that we can see that the whole theory behind 90-90-90, the theory that you get people tested and you get people onto treatment, that this actually really makes a difference in practice.
What do you think the game changer will be, and when do you think it will happen?
Well, I think for me it's self-testing. If that can be picked up, then we can probably reach one of our first 90s. And self-testing, when somebody is diagnosed and linked to care, it will mean more people will get virally suppressed. So I think we'll be able to achieve the UNAIDS 90-90-90.
Roger?
I don't want to be too obvious, but I will be. I mean, for me, the obvious game changer in that conference was the opposites attract data. And but actually the question, when will it happen? I mean, part of when it will happen is when HIV-negative people, including HIV-negative gay men, actually understand that and completely take it on board. And I'm not overly optimistic on that point just because of how deep stigma is running. I mean, clearly that data runs against stigma and it can help to dissolve it, but I don't think that's going to disappear overnight.
Gus?
I don't think there's a game changer as such, because my experience is that HIV developments happen slowly. I think the game change has already started to happen, and that's tremendously exciting. One of the symptoms was the HIV incidence falling in London clinics last year. None of us expected it. But I think in different populations, what 1990 has behind it as a philosophy, in different populations, there is a tipping point. And that's the point at which enough people with HIV get undetectable and enough negative people either test or get on PrEP that you cut the chain of transmission. And then, as we can see, HIV, with Swaziland of all places, HIV incidence can start to fall very fast. And I think, excitingly, we are reaching that tipping point in certain parts of the world. And what you need is the sort of model that works best, which is what the French study was so interesting about.
And finally, Tristan.
I can't believe I got away with this. I thought I'd have nothing left, but I've been left with PrEP. I can't not say PrEP. The numbers might only be 10,000, but England's getting PrEP. And I think, the chink in that wall has opened in that dam, and I'm sure the flood will push away the rest of the wall. I think we need to also remember, I think it was pointed out, I think Roger pointed it out, that Paris are offering this more general access to PrEP. We need to remember that PrEP is not only for one population, and all those at risk need to push for access, and that will really be a game changer in terms of new diagnoses.